Okay, so I'm gonna talk about negative pressure wound therapy, evidence from Benchtop to Bedside, and so I was new faculty. So UT Health Science Center in San Antonio is literally down the road from KCI. So when this technology was launched, we were one of the first groups that kind of used the technology, and at the time, it was similar to a 1967 Volkswagen Beetle. It was big, it was noisy. You didn't have the elegant tools to apply the technology. And KCI came to us and said, use this on your worst patients. Well, that didn't work out that well. But we kind of learned, kind of like what Mike was saying. We started out, we're gonna have the people that couldn't be bypassed, and then went, okay, maybe we need to move our patient population a little bit one way or the other. So these are my conflicts. So I really want to talk about the mechanism of action, and I think it's interesting because a lot of people, so everyone in the room with gray hair or no hair probably was around when this was launched, where the mechanism of action in animal studies were discussed. New people in training don't know that information. They don't know where this technology came from or some of the foundational issues. So I'm going to talk a little bit about the mechanism. I'm going to talk about negative pressure wound therapy outcomes, and then I'm going to talk about negative pressure with irrigation outcomes. So this all started in an animal lab in Wake Forest. If you look at some of the early Wake Forest studies, as we were trying to reproduce some of these, you wonder, how long were the animals sedated? How did they keep the vac on them? Because they didn't have, a smaller vac. They didn't have the technology to have a vac over the animal's head like this product right here. So it's, I read that one. How the hell did they do that? Oh, geez, I'm going the wrong way. So I really want to talk about two parts of their mechanism of action. Their perfusion. So yeah, if you ask someone, why do you use 175 millimeters of mercury? And it's like, well, God ordained it. It's like, that's what they were taught and that's what they do. So I think some of this came from their animal studies where they looked at intermittent pressure and continuous pressure and said, wow, we get the best response at 125 millimeters of mercury. And after about 400 millimeters of mercury, there's a reduction. It's decreased. And so we should use 125 millimeters of mercury. Then studies of a few years later, so what's this, 2010, looked at, and so their original studies were in subcutaneous laser Doppler studies. So they're unitless measurements. So this study was reproduced, and they used this in subcutaneous tissue and in muscle at 0.5 centimeter, 2.5 centimeters, and 5 centimeters, and showed that if you're close to the wound, you actually create a hypoxic area. So these are in healthy pigs, that you cannot make their wound not heal, not in someone with diabetes that was just revascularized. So, the close to the wound, you actually are creating an ischemic zone, and at 2.5 centimeters, it improves. At 5 centimeters, there's no difference. So really flies in the face of, the foundations of the faith from Wake Forest. So this is just a reiteration of that. So no human data had really done that. So this is a clinical study comparing 75 millimeters of mercury and 125 millimeters of mercury. And we looked at wound area reduction and wound volume reduction, and there's absolutely no difference in if you use a lower pressure or not. It's just everyone does 125 because that's the foundations of the faith. What about decreasing bowel burden? So, I think this really came at a time, I think when, probably J&J was convincing everyone, you can't see it, but there's a level of bacteria in your wound that's stopping the wound from healing, and you need a $10 silver dressing. And so, there's a threshold of bacteria that we need to get under that is going to cause infection. So this was a study where they inoculated animals with bacteria, and they looked at change in quantitative bacterial cultures over time. Now, colony forming units now, it's hard to find a lab that will do that, that uses that technology. We're trying to do a study for an NIH grant, and there was the UT Dallas, biochemistry or microbiology was going to have a separate setup to do that because they don't do it anymore. So this is the study from Wake Forest that looks at, so this is 10 to the 5th bacteria. That's the threshold. We were all taught that that's the threshold for infection. And at day 4, there's a decrease when you use negative pressure wound therapy. There's an increase when you don't. So, if you extrapolate that, they're telling you we're going to reduce infection. There's none of the negative pressure wound therapy technology in diabetic foot wounds shows that it reduces infection. So this is a meta-analysis that Arthur did that looked at wound healing with negative pressure wound therapy, traditional negative pressure wound therapy, 1.5-fold more likely to heal, shorter healing times, about a 2-week shorter healing time to heal, significantly fewer amputations, no effect on adverse events, primarily infection. So this is the first randomized clinical study that was surgical wounds, so large 15-centimeter surgical wounds. 77 people were treated with negative pressure wound therapy. 86 got standard of care for 16 weeks. There's a higher proportion of wounds. I mean, the 39% for a 15-centimeter wound to be healed in 16 weeks is better than most phase 3 or phase 4 diabetic foot ulcer studies with 2-centimeter wounds instead of 15-centimeter wounds. Faster healing times, no difference in amputations or infections. And the majority of wounds healed by secondary intention. So really a paradigm shift, I think, in how we handle this technology now. We at least in our center and other people that I have collaborated with, use this as an interim measure. They get back for a few weeks, they get covered with a synthetic graft, and then they get skin grafted, or they get surgically closed. So, I think it's to have, 10 or 15% of your patients healed by secondary intention, I think is, the exception and not the rule today. This you can see this is the survival analysis. You can see there's a departure very early in the wound healing trajectories in these people. Almost a difference in amputations, and if you look at the negative pressure wound therapy group, there are no major amputations, only 2 in the standard no major amputations in negative pressure wound therapy, 5 in the standard of care group, and 10% or 15% overall. Most of the other studies show a difference in major amputations. If you look at the other studies in this space, and now there's a growing body, I thought we were probably done with comparing this to standard of care. But in the study that was published in The Lancet, and Peter Bloom's study, which was diabetic foot ulcers, there was not a difference in infection. And other studies just don't report infection specifically as an adverse event. It seems like you should, and if there is, I would suggest it's probably an exposure variable. The wounds are just open for a shorter period of time and therefore less likely to heal. What about irrigation? So, the thought of, having quantitative bacterial or a level of quantitative bacteria in your wound that's going to cause infection. So this is from my lab at UT Health Science Center, where we've done a couple of these projects to see if we could have an irrigation as part of the wound therapy that was either antiseptic or even normal saline, if that would reduce the infection rate. So this is one of the studies we did where we looked at Prontosan or normal saline. We looked at low rates of irrigation or high rates of irrigation. And this was a product where you would get constant irrigation. The KCI product has installation or periodic irrigation. So you stop the negative pressure wound therapy, you infuse some fluid, you hold it for a minute or 2 minutes or 30 minutes, and then you start the negative pressure wound therapy process again. It sucks all the irrigation out, and you start negative pressure wound therapy, and you can change the timing, really a huge number of variations. So let's go here. So we infected these animals with 500 CFUs of a known Pseudomonas strain. We put them under occlusion, and then we took them to the OR, washed them out, took cultures, and then we continued therapy. We changed their dressings every Tuesday and Friday for 21 days. So, this is a log of the irrigation that we measured that we gave. So we were close to giving them 15 cc's and 40 cc's of treatment. So if you look at the level of Pseudomonas, it's a lot better than negative pressure wound therapy alone or the control group. It is best in the Prontosan groups compared to these other therapies. So you think, oh, this is it. This is awesome. But if you look at their wound healing, no difference in wound healing. And so if you look at their wound healing trajectories, all of these lines overlap. The only difference is when you compare them to standard of care. So of course, despite that, we looked at randomized clinical studies. So this is Timmers. He's one of a Dutch orthopedic surgeon that looked at a retrospective series where he looked at pelvis and lower extremity traumatic wounds that got irrigation, and he didn't use a KCI product. He used wall suction. So he used a Prontosan irrigation for 10 or 15 minutes. He used 300 millimeters of mercury to 600 millimeters of mercury for 19 to 21 days, and showed significant difference in the fewer infections, shorter hospital stay, fewer additional surgical procedures. So we did 3 clinical trials. We did two from our centers. One was funded by the ADA. One was funded by a negative pressure wound therapy company. And then we did a study where Paul Kim was the PI that was sponsored by KCI. All 3 of the studies didn't show an improvement in clinical outcomes except for reduction in quantitative bacterial cultures if you got irrigation. So there were, the number of surgeries wasn't different. The rate of closure wasn't different. Let me go here. The length of stay wasn't different. The number of adverse events, including infection, wasn't different. So, I mean, it's interesting that one of the papers that was talked about quantitative bacterial cultures and then buried the lead. This didn't really change any of your clinical outcomes. So this is a technology that's a little bit complex if you're in a big hospital. So I basically, at the time, was in 2 800 or 900 bed hospitals. And it's really hard to educate the nursing staff about how you use irrigation and what you should do when there's a problem. So this is just a survival analysis of one of our studies that shows the healing rate is exactly the same. Oh gosh, this is the wrong summary. Anyway, so I will. Let me go to my. I will stop by saying, I think we still don't know a lot of the parameters because it's like 125 works, we're going with that. I think there's not very much evidence that irrigation is going to be helpful. We've only looked at normal saline and Prontosan. We looked at Prontosan in all 3 of the studies we did. It's a lot of extra effort for not much gain. So with that, I will stop and go to my next talk.